survivorship. Please prepare to also watch the footage that highlights Parkland's commitment to the community with testimonials and Parkland's investment to continue improving the quality of care in the community with the opening of our new Parkland Breast Health Center in the Moody Outpatient Center. This week, we have a powerhouse of experts from the system, delivering this session in both English and Spanish. I'm excited that you've decided to join us, and welcome again.
Good morning. My name is Joe Black. I am a Community Development Specialist for Parkland Health and Hospital Systems. Thank you for joining us for Coming Together for the Cure 2021. As said earlier, we have gone virtual this year to ensure the safety of everyone that's involved. We have speakers that will bring topics regarding breast cancer. And this is all week. So we start Monday and we actually end on Saturday. Each day this week, the event is virtual. We end with an in-person event on Saturday at Salem Institutional Baptist Church in Dallas, Texas. The address is 3918 Crozier, Dallas, Texas, 75215. At that event, we will have mammograms, we will have flu shots, we will have screenings for blood pressure and glucose, and we'll have food and fun for everyone. So once again, thank you guys for joining us for 2021 Coming Together for the Cure, and we look forward to seeing you all week long. So I would like to introduce Ms. Aisha Taylor. She's going to talk to you this morning about, she's from the mammography unit, and she's going to talk about breast self-awareness. Breast self-awareness. Ms. Aisha?
Hello, everyone, and thank you for having me. My name is Aisha Taylor, and I am a mammography patient health educator at the Moody Breast Center. And I'm very excited to help kick off this event. I mean, this is October, breast cancer awareness. Everyone's sporting their pink. There's different walks and events going on. And so we're all excited about breast cancer awareness. But we want to make sure that we're being aware of our breasts not just in October. And I'm just waiting for my slide to come up. So I've been in the mammography field for about 8 years as a mammographer, breast navigator, and now patient health educator. So I'm always very excited when it comes to breast health awareness. But the one thing I want to make sure that ladies know is that it's not just one time a month, once a year, it's every month. And so I'm going to go to the next slide. So we're going to go back. So we're going to be talking about breast self-awareness. And so for me, I'm going to talk about, are you in the know? And so that just means being informed. That means being knowledgeable. That means having inside information. And so if we bring that to everyday life, there's people that you may know, or maybe it's you that's always in the know. Whether it's with fashion, you're the first to know what's coming out, or whether you're tech savvy, maybe you keep the latest, greatest phones, or maybe you always have the inside scoop. Whatever it is, we like being in the know. So what's so different about with our breast? We want to be in the know when it comes to our breasts. Next slide, please. Okay, so I work with a foundation called the Know Your Lemons Foundation, and They use lemons to represent breast, and so it's kind of a fun way. It's very eye-catching. It's something that's very relatable to everyone. So if you look at these lemons, they look normal. They're yellow, they're round, everything looks normal about them. So we're going to refer to these as lemons, but we're going to be talking about breasts. So I'm going to ask you, do you know your lemons? Next slide, please. So if you look at this lemon here, the one that's open, there's a seed, and that seed represents breast cancer. So on the previous slide, the lemon looks just normal like any other lemon. But when you actually look inside, there is a seed. And for us with breast cancer, you truly don't know what's inside unless you're having your mammogram. So we ask the question, do you really know your lemons? 1 in 8 women in the US will develop breast cancer in her lifetime. Next slide, please. So it really helps for you to be breast aware. And by being breast self-aware, I'm going to ask some questions to see if you are breast aware. So do you know your breast health status? Do you know your risk for breast cancer? Do you know how your breasts normally look and feel? Do you know the signs and symptoms that should be reported to your doctor? And do you know the truth? Next slide, please. So we'll start with breast health status. Breast health status is just knowing in what condition your breasts are in. The best way to know what condition your breasts are in is with a mammogram. Mammograms are key in early detection of breast cancer. Next slide, please. And so the saying is so true, the best protection is early detection. The earlier that we can find breast cancer, there's typically less treatment and your chances for survival are higher. Versus waiting in the latter stage, more treatment is necessary and the chances for survival are lower. So I also want to point out that we say that the best protection is early detection. We don't say that mammograms prevent breast cancer. Mammograms are there to detect breast cancer. And so they still remain the golden standard of the way to find breast cancer. Next slide, please. And so you really want to make sure that you know your risk for breast cancer. And that's important because knowing your risk for breast cancer, whether you're average risk or high risk, is very important because it's going to determine at what age you start having your mammogram. So next slide, please. So a common question that I get while I'm out in the community is, what age should I start having my mammogram? And that, again, it depends on where you fall with your risk. So currently the guidelines, American College of Radiology and the Society of Breast Imaging recommend that an assessment should be completed at the age of 30. So that means seeing your provider at the age of 30, and your provider will take into account your personal history, your family history, and any kind of genetic history in making an assessment to see if you need to be screened before the age of 40, which is very important, especially in communities where the population is high risk. So what determines if you're average risk or high risk? So a person who is of average risk, they have no personal history of breast cancer, or they don't have a strong family history of breast cancer, or any genes that increase the risk for breast cancer. And so when we talk about family history, we want to make sure we say a strong family history. So that's someone who's like a parent, a brother, sister, or a child. So for high risk, the opposite is true. They may have a personal history of breast cancer or a strong family history of breast cancer, or they may have had radiation therapy to the chest between the ages of 10 and 30. And that's not to be confused with x-rays. It's radiation therapy. So now, just like I'm often asked the question, what age should I start having my mammogram? I'm always asked the question, what age can I stop these things? So But the recommendation right now is that you continue to have your mammogram beyond the age of 74, unless there's some kind of terminal illness that would decrease your life expectancy. So next slide, please. All right, so when we're talking about risk factors, there's some risk that you just cannot change. You were born with them and you can't change them. Now, there are some that you can change, and those typically relate to lifestyle. But next slide, please. I'm just going to show some examples here. So getting older, your age, you don't have any control over that. The age in which you start your period. These are some things that you really don't have control over. Your gender. Being female is one of the number one risk factors for breast cancer. That's something you can't control. But the things you can control, which are like lack of physical activity, which often leads to being overweight or obese. These are things you can control by being more active, watching your nutrition, your lifestyle habits, smoking, drinking. These are things that you can do to lower your risk. Next slide, please. All right, so minority women are more likely to be diagnosed with breast cancer before the age of 50, and they're more likely to be diagnosed with late-stage disease before 50. And they're more likely to die of breast cancer when compared to white women. And you can see the percentages there. And this is why an assessment is so important, because your provider will take into account all of these risk factors and all of your background to make an imaging plan that's specific to you. Okay, next slide, please. All right, so knowing how your breasts normally look and feel is very important when it comes to breast self-awareness. And actually, that is the very definition of breast self-awareness, knowing how your breasts normally look and feel, knowing what's normal for you. And I always ask questions to my patient to say, how do you know what's not normal for you if you don't know what's normal? So the best way to know what's normal for you, if you want to know what's normal, if you want to know how your breasts normally look and feel, then the best way to do that is to feel your breasts and look at your breasts normally on a regular basis. Next slide, please. And then breast self-awareness is just what we talked about. So the breast self-exam is the best way to do that. The best time to perform your breast self-exam is 5 to 7 days after your period, about a week roughly after your period has ended. If you don't have a period, then you're just going to choose the same day of the month each month. You just want to be consistent. And one of the things that I've found is being consistent is the key when it comes to breast self-awareness. That's with your mammogram, making sure that you consistently have it every year. And making sure that you're checking your breasts. So where can you perform this, or where should you perform it? It's in the shower, in the bed, or when you're doing your visual check, you want to make sure that you're in front of a mirror. And how you're going to do it, you're going to use your hands and your eyes both. So I know that some people will do the breast self-exam just with the hand, but they don't visually look at their breasts. So you want to make sure that you're looking at your breasts in the mirror. And we're doing the breast self-exam so that we can notice or recognize changes or symptoms that need to be reported to your doctor. So you don't want to delay. If you see any of the signs and symptoms, the key is not to delay reporting it to your doctor. Because as we said before, early detection is the best protection. Next slide, please. So a lot of people will come in, and I'm so excited. I'm so happy to be the breast educator here, because I think we take for granted that women who come for their mammogram every year really know how to perform a breast exam or know the importance of it. And it's so interesting to me that ladies that come for their mammogram go, I just never have known, I don't know how to do one. And so, of course, we have literature. We actually do demonstrations. We have to show patients how to do their breast self-exam. And so for number one, you want to make sure that you're using all the highlighted areas on the 3 fingertips, you want to use those 3 fingers. And for number 2, you want to make sure that you're covering the whole area when you're examining the breast. And so you'll use like from gentle to firm pressure. You'll use varying pressures when you're feeling the breast. You want to make sure that you go underneath the armpit all the way down to your rib and back around just underneath the collarbone. And that's very important because most people tell me that they just stay on what we call the mound of the breast, like right over the nipple area and just a little bit above. But it's very important to cover the entire area because we find breast cancers in all of those areas. So just make sure you're covering the same areas of the breast at home. And so number 3 just highlights the different patterns of the breast, the breast patterns you can use to examine the breast. You can go up and down, or you can go around. It doesn't matter which pattern you use, just as long as you're consistent and you do that for both breasts and you cover the whole area. And number 4, you just want to pay attention to the nipple as well. You don't want to skip over it because sometimes there's masses right behind the nipple. So you want to make sure that you are checking your nipples as well, and you're noting any kind of fluid leakage or any swelling or redness. So the next slide is going to be the mirror self-check. And so this is the part where I'm saying you're actually looking at your breast. In the mirror, you want to make sure you're in a well-lit place. You want to make sure that it's warm. If it's cold, you might rush through it. So make sure it's in a warm environment. And I'm actually going to go to the next slide because you want to know, what am I looking for? What am I looking for when I'm looking in the mirror? So knowing the signs and symptoms will help you to be able to report these things to your doctor in a timely fashion. So what you're looking for, we're going to go to the next slide. At the knowyourlemons.com website, they have all of these signs and symptoms, and they go over all of them. But these are some of the things that you're looking for. These are changes that are new. And so you're going to pay attention to your nipple. You're going to look in the mirror. If your nipple normally sticks out and it starts to sink in, that is going to be an indicator I need to call my provider and talk to them. New size, new shape. And what we mean by that is, okay, we're not all the same. So one breast sometimes is bigger than the other, and that's what can be normal for you. Most people are not just symmetric. So what we're speaking of are abnormal changes. One breast has really gotten small, or one has gotten really large and swollen. Those are the things that we're looking at. Pay attention to your skin. If the texture of your skin changes to where it looks like an orange peel or like a lemon peel, that's something that that indicates you need to speak with your doctor. So you can look at all of these signs and symptoms at the knowyourlemons.com website, and it'll go into depth for it. But I always say it's better to be safer than sorry. If you, I would not wait to see if something is going to resolve itself. You want to make sure that you contact your doctor. Next slide, please. All right. So one of the things I said is, do you know the truth? And I think Dr. Hayes is going to be speaking on the myths of mammography, which is very important. There's a lot of myths out there. So one of the things in knowing the truth is you want to make sure that you're literate when it comes to health. And that just means knowing your options. That means knowing how to advocate for yourself and ask questions. You want to choose facts over fear. And then I have some mammography tips for you. So next slide, please. All right. So with health literacy, your outlook on health matters. And this is near and dear to me because my grandmother, she, at the age of 11, lost her mother. And she basically became a mother to her siblings, her 6 or 7 siblings, herself at 11 while her dad worked. And so she really, for a better, or lack, how can I say, for a lack of better words, she really became a mom at 11 to try to help these other kids when she herself was still a kid. And at 17, she ended up with starting her own family, which eventually was 8 kids. And so, if you can only imagine just going through that, health was not at the forefront of her thought process. She was more focused on surviving and providing for her children. And so, later on in life, that impacted the outlook that my mom had on health, or her lack of outlook on health, because that really wasn't presented to her. So your personal outlook on health can impact generations. And so you want to make sure that you're informed, and you're informed from reliable sources. And I always tell people to just be careful on social media platforms. Check the sources. If you find information on there, make sure it's with regarding breast health. Make sure that it's reliable, or anything for that matter. For breast health, I always like to use the American College of Radiology or the Society of Breast Imaging. And then make sure that you are the change if it's necessary within your family, which for me, I was the curious kid. And so I'm always asking why. And I think that's what led me to the medical field. I had a lot of questions. And actually, I began to share my knowledge with my mom and my grandmother before my grandmother passed. But now I've noticed changes within my family. My sister is getting her mammogram. My mother is getting her mammogram. We kind of make a date of it for me and my mom. And now I'm passing that knowledge down to my family, which you can see in the top left. And not only just to my daughter, but to my son and to my husband as well. So I just wanted to make that known, that you can be the change, and just make sure that the information you're giving is reliable. Next slide, please. All right. So in knowing the truth, there's a lot of fear out in our community. And so some of the things are the two main things that I hear when I'm in the community is, I don't want to have it. I'm scared of the pain. I've heard that it hurts. I don't want to be squeezed. And also, I don't want to get too much radiation. So for me, I believe fear comes from unanswered questions or not knowing. And so for the most part, mammograms are 15 minutes or less. They consist of about 4 pictures, depending on the size and the shape of the breast. And compression is really quick. It's a matter of seconds with each image. It's not constant. So contrary to the pictures that are put out there, we don't leave you in compression and go have a coffee break or anything like that. It's really quick. And also, I usually tell people, if I know the reason something is being done, I usually can. I say I'm more willing to cooperate, or it puts my mind a little bit more at ease of why I'm having, or why this is being done. So it's not that we want to hurt you or anything like that. We want to make it as comfortable as possible. But compression is used to spread the breast tissues so that if there's anything there, the radiologist, the doctor who's going to read your mammogram, can see it. And also, compression helps to keep the breast still. So we don't want a blurry picture. So if there's any movement there, it can degrade the picture that's going to be shown to the doctor. So we try to make sure that we compress to keep the breast still, and it actually helps reduce the amount of radiation that's needed. So as far as the fear of radiation, you always want to weigh the benefits versus the risk when you're having a procedure or an exam. And so your benefit of knowing whether there's a breast cancer there is is more beneficial, or it's actually better than not knowing. If there was a potential cancer there, untreated and undiagnosed, it's more harmful to you than the dose of radiation that you're receiving from the mammogram. So next slide, please. Going down the what if road, that is a big thing for a lot of the ladies in our community that I speak to. They have a fear of the results. I just don't want to know. I'm scared. So you can see the sign there. There's the sign pointing to trust, and then there's the sign pointing to fear. For whatever reason, we always go down the fear road. We go down to the what if. What if I'm a callback? What if I need a biopsy? What if the biopsy is positive for cancer? And so next slide, please. Um, so these are some tips that I give to handle both of those, the fear of the pain, radiation, the fear of the results. First, for the pain, I always tell you, do not schedule your mammogram close to or during your period when your breasts are most tender. And that's for obvious reasons. If you're tender or your breasts are sore during that time, we probably won't get as much compression as you might let us do without the tenderness or soreness. And it would just be more comfortable for you as well as not being on your period. So for me, as I've aged a little bit, I have become really sensitive to caffeine, and I can tell it can make my breast tender and sore. And so some of the tips that I give is just stop or lessen your caffeine intake about 1 week prior to your mammogram to see if that will help. And then the other thing is do your best to relax when you're being positioned. As a mammographer and also as a patient who gets her mammogram every year, I know that being relaxed really helps. For one thing, if you think about it like when you're going to get a shot, they tell you, hey, if you tense up your arm, it's going to hurt worse. So try to relax your arm. It's the same concept with your breast. If we're compressing and you're pulling against, then it's going to be a little bit more uncomfortable. So not only is it more uncomfortable, but if you're pulling against it, it may take some of your breast tissue out of the image that your doctor needs to see. So the best thing is to just talk to your mammographer, and most mammographers are talking to you during the exam as well. So you want to make sure that you discuss your fears and concerns with a trusted healthcare professional and ask questions. Remember, fear sometimes is unanswered questions. And the last thing is don't let a bad experience, whether it's yours, a personal one, or someone else's bad experience, keep you from knowing your breast health. It's more important for you to know what's going on with your breast. And I'm sorry, next slide, please. The tips to remember, the best protection is early detection, and that is with mammography. And one thing I did want to say is your breast self-exam is very important, but it can never ever replace your mammogram. Make sure that you have your mammogram. Your mammogram can feel things or actually detect things that can't be felt by you or your provider. So you want to make sure that you're having your mammogram. We always say we want to find it on the mammogram before you can feel it with your hand. So make sure you know your breast health status, know how your breasts normally look and feel, and know the signs and symptoms, and make sure that you know the truth and be in the know when it comes to your breasts so that you truly can, last slide, know your limits. Thank you.
Was really such a wonderful PowerPoint and presentation. I've never seen the Know Your Lemons, and the visual was just great. So thank you for that. It will be something that I'd like to share in the communities. One thing I'd like to say about working for Parkland is when I see people do these different PowerPoints or presentations for breast health, I always learn something new. It doesn't matter how long I've been working in communities. Each person brings something different, and Know Your Lemons was new to me, so thank you for that. Speaking of breast health, I'd like to let you guys know that we have a new Center for Breast Health, the Moody Center for Breast Health. It is located at 5151 Maple Avenue, and we'd like to give you guys a quick virtual tour of our state-of-the-art facility.
includes breast imaging and the breast clinic. The Breast Imaging Center provides a full range of breast screening and diagnostic services in one central location, including mammograms, ultrasound, MRI, biopsies, stereotactic core biopsy, and the most advanced technology with 3D mammography. Our highly trained staff will be able to help you through the process of getting screened in a comfortable and calm environment. The Breast Imaging Center is connected to the breast clinic, which is home to breast surgery and breast oncology providers and other members of your care team. Your care team
Thank you for staying with us, and I hope you guys enjoyed the video and was able to see all of the things that we have to offer. So next we have Dr. Jody Hayes, Breast Imaging Fellowship Resident and Medical Student Ambassador, Assistant Professor, and she will be addressing breast cancer myths. Dr. Hayes.
Hi, I'm Dr. Hayes, and I'm an assistant professor of breast imaging with UT Southwestern, and I'm stationed primarily at the new Moody Breast Center, which you just saw the video of. It's a fantastic center, so I hope everybody gets to come out and see us at some point. Over the next 10 to 15 minutes, what I really wanted to do is bust some common breast cancer myths that we see or hear quite often and arm you with some truths. So if we'll go to the first slide. This is a myth that we actually hear quite often in our clinics, that only women with a family history will get breast cancer. Next slide. The truth is 70% of breast cancer patients that we see actually have no risk factors. So if you do have a family history of breast cancer, who in your family is affected will actually greatly influence your risk. So first degree relatives are somebody very close to you, your parent, sibling, or child. A first degree relative, if you have one that's affected, it doubles your risk. But if you have two or more affected, it can increase your risk up to 5 times. Second degree relatives are relatives that are a little bit more remote to you, like your aunt, your grandmother, nieces, cousins. Second degree relatives will increase your risk of breast cancer just slightly. But if you have multiple generations affected on the same side of your family, that can increase the probability that there's a breast cancer gene in that family that we need to diagnose. So if you have a situation like that, you might actually qualify for genetic counseling. Next slide. Myth: young women don't get breast cancer. Next slide. The fact is that all women are at risk of breast cancer. 7 in 10 cases of breast cancer are diagnosed in older women, women older than around 55 years. 5% of breast cancers are diagnosed in women below the age of 40, but that leaves 25% of breast cancers that are diagnosed between 40 and 54. That's a large number. You may hear in the media or newspapers from even your own doctor that we're recommending that breast cancer screening start later than 40. That actually is not what we're recommending at all. Since there's 25% of breast cancer that will occur between 40 and 54, we still think the best time to start screening is when you turn 40, and you need to have screens done every year so that we can keep a very close eye on your tissue. We can't prevent you from getting breast cancer, but our job is to find it when it's at its smallest, earliest stage so that we can get the cancer out and get you under treatment and increase your risk of your chances of surviving. Next slide. Myth: men don't get breast cancer. Next slide. Breast cancer is not as common in men, but 1% of breast cancers will occur in men. Each year, around 2,600 men are diagnosed with breast cancer, and sadly, about 500 will die. That's about 20% of men that are diagnosed will die from breast cancer. Men are dying more from breast cancer than women. That's because of a few different things. One, it's not a population that we typically screen. So there is less awareness in the male population. Often that can lead to a delay in treatment so that the men that are presenting with their breast cancer are at a later stage. So men sometimes can actually qualify for screening. The men that we actually want to make sure we're getting into our screening populations are men that have certain syndromes. Those are usually any syndrome that will increase estrogen in a man, or men that are undergoing hormone therapy with estrogens. So men that fit some specific situations actually will qualify for screening. But it is important to know for the men in your life that they still can get breast cancer. So it is always a good idea to have a mass or a symptom in the breast of a man checked out by a physician. Next slide. Myth: a woman can't get breast cancer if she's pregnant. Next slide. The truth is that breast cancer is the most common type of cancer that's diagnosed in pregnant women and women who have just had babies. So when you're pregnant or breastfeeding or have just delivered, you're in a high hormone state, mainly estrogen and progesterone. A lot of the breast cancers are responsive to estrogen and progesterone. So this makes it a very dangerous time for a breast cancer to develop in a woman. So we just caution everyone that if you have a mass or a concerning finding in your breast when you're pregnant, make sure that you're letting your doctor know and make sure that you're getting that checked. Next slide. Myth: breast cancer always forms a lump. Next slide. Ms. Taylor went through a lot of this for us. So, not all breast cancers do present as lumps. This is just going to be a little bit of a review of some of the things that she was discussing. So when you do your breast exam, you're definitely checking for a lump in your breast. And like she said, make sure you're extending out to your armpit and you're checking for lumps in your armpit. But also make sure that you're looking at other things such as a texture change of your skin to start becoming thicker or rubbery or have an orange peel appearance. That can be a sign of cancer. A dimpling in your skin or an inversion or retraction of your nipple can be also a sign of breast cancer. Redness or a rash on your skin can be signs of infection or inflammation, but if it's generalized on your breast, it can be a sign of breast cancer. But still, any of those conditions you would want a breast expert to help you with. So if you have redness or a rash, especially a rash of the nipple, those are definitely things that we should be looking for. Nipple discharge. Bloody nipple discharge and clear nipple discharge are definitely discharges that we want to address and we want to work up. Milky discharge or some other colors like yellow and green, a lot of times those discharges are not concerning, especially if you're squeezing them out yourself. But again, bloody discharge and clear discharge, especially if they're coming out on their own, we do want to address. Next slide. Myth, wearing an underwire bra can cause breast cancer. Next slide. The fact is that there's been no scientific proof that bras of any kind cause breast cancer. And in fact, your bra, especially a well-fitted bra, can actually help decrease breast pain. Breast pain is a symptom that you may have noticed was missing from that last slide discussing symptoms of breast cancer. Breast pain is almost always benign. So breast pain is usually caused by hormones, but sometimes, especially if your bra is not fitting well, breast pain can be caused from stretching and pulling of the ligaments in the breast. So a bra will not cause breast cancer and can actually help reduce some of your problems. Next slide. Myth, putting a cell phone in your bra can cause breast cancer. Next slide. The fact is there's been no scientific proof that cell phones can cause breast cancer. Apparently, purse bras are a thing. I did not realize until I got prepared to do this talk. But it's not dangerous to store things in your bra. It's not going to cause breast cancer. Cell phones actually don't run off radiation. And something that increases the radiation dose to your breast could cause breast cancer. So if you have a history of radiation to your chest for treatment of cancer, such as lymphoma, or one of the, maybe a lung cancer, if you've had radiation to the breast, that can increase your risk of cancer. But again, cell phones don't cause that, so they're not dangerous. And chocolate in your bra is not dangerous to your breast, it may be dangerous to your chocolate. So not something I would store there, but it's okay to actually store things there if you need to. Next slide. Myth, deodorant causes breast cancer. Next slide. The fact is, research has found no link between deodorant use and breast cancer. This comes up every now and then because there's certain things in deodorants like parabens, aluminum, toxins, preservatives, and that people try to link to breast cancer. But all the research has shown, so far, nothing has been shown from deodorants or hair color or hair straightener to cause any type of breast cancer. And next slide. Myth, women of color are more likely to get breast cancer. Next slide. The fact is, more white women are diagnosed with breast cancer, but more Black women will die from breast cancer. So this data is from the SEER data. And as you look across this graph here on the bottom, The blue bars are your incidence of breast cancer. So that's how many breast cancers we're diagnosing in those certain populations. And then the orange bars are how many women are dying from it. And you'll see that the highest blue bar is actually in white women, but the white women that are dying are less than the Black women that are dying. We are actively researching why we have a higher death rate in the African American population. Sometimes it isn't access to care. Sometimes there are just different things, like if you look between the Hispanic mortality and the African American mortality, breast feeding is actually protective. Our Hispanic population tends to breastfeed a lot more and a lot longer than a lot of our other populations. And you'll notice that their mortality from breast cancer is half of that of the African American population. So there's definitely some things that we can still explore on the research side of why there is such a difference, but it's definitely something to be aware of. We do know that African American women are diagnosed with more aggressive cancers than some of the other populations. And again, we're actively researching that, but it is something to be vigilant about. If you have a mass in a young African American female, or if you are a young African American female, definitely make sure that you're getting that checked. Next slide. Myth: nothing can change my risk of breast cancer. Next slide. The fact is that more than a third, or around a third, of breast cancers may not actually have to happen. Research has shown that patients with higher physical activity have a 10 to 20% lower rate of breast cancer. Part of this is, again, because estrogen and some of these hormones that we know are present in, or the receptors are present in breast cancer, are stored in our fat. And so if you can maintain a healthy weight throughout your life, which means more movement, exercise more, decrease your alcohol risk, all of those things can actually lower your risk of breast cancer. Breastfeeding, like we talked about just a minute ago, can decrease your risk of breast cancer. Research has shown that you can decrease your risk of breast cancer for every year you breastfeed a child. It decreases your risk by about 4%, and that's cumulative throughout your life. There are certain risk factors that you can't control, such as when you start your period or when you end your period, or having children, later. If you have children over 25 or 30, it's more protective to have them below a certain age than above a certain age, but those are not necessarily things that we can control. However, your health and moving and decreasing certain lifestyle choices, those actually can impact your risk of breast cancer. Next slide. And again, as we were discussing earlier, please remember to get your screening mammogram. So as I said, we can't prevent you from getting cancer, but we really can do everything we can to decrease what happens after you get a cancer. But to do that, you have to come in for your screening exams. Thank you.
Thank you, Dr. Hayes, for that information and for addressing the myths that have been around forever. It seems like with the myths that we hear, they tend to change with the times. I've heard the one about the underwire forever, and now it's the cell phones. So one of the things that Aisha said was make sure that you get your information from professionals rather than social media, because we see all of these scare tactics and things that have no validity. So make sure and get your information from someone that is going to give you valid information. And with that being said, I would like to let you guys know that our panelists will be here throughout. So if you have questions, you can begin to submit those through the chat. and we can get those to these professionals to answer those questions for you. So this way, we're not continuing to pass along myths and things that are unfounded, and we can give our friends, our sisters, our communities valid information. Our next presenter is going to be Dr. Priyanka, and she is going to discuss breast imaging and steps to care.
Hi, everyone. Thank you. My name is Dr. Paremka, and I'm an associate professor in radiology at UT Southwestern. I'm also the medical director for Parkland's breast imaging. So thank you so much for giving me the opportunity to come talk today. If we can go to the next slide, please. So in breast imaging, we have a lot of exams, and I wanted to walk us through the different types of exams that we had. We can go to the next slide, please. We'll start with screening mammography with tomosynthesis. So some of the questions that we want to ask is, what is it? Why is it important? Who should get it and when? And we're also going to answer those questions with this presentation. Can you go to the next slide, please? Okay, so in terms of what is it and what to expect during a mammogram, you can expect to fill out a history sheet that sort of talks about any current symptoms, any problems that you might be experiencing, family history of breast cancer and things like that. You also can expect that each breast will be compressed horizontally between two imaging plates and then also diagonally. And you can go to the next slide, please. So basically that means 4 mammographic views depending on the size of the breast and 2 views for each breast. I also want to talk a little bit about digital breast tomosynthesis, something that people have probably heard about, and I know that Ms. Taylor and Dr. Hayes probably talked a little bit about tomosynthesis too, the 3D mammography. So 3D mammography basically means you get multiple images of the breast rather than a single 2D image. And breast radiologists can scroll through these images to help see through the tissue of the breast in thin layers. It's the same positioning and compression as 2D mammography. Can we go to the next slide, please? Some of the benefits of digital breast tomosynthesis or 3D mammography is that there are fewer false alarms. And false alarms basically just mean that we see something that we think may be abnormal, but it's not cancer. And so we may have to call someone back for something that looks a little bit funny on the mammogram, but it doesn't end up being cancer. 3D mammography can decrease those false alarms by up to 40%. And you know, one of the issues with false alarms is that it can produce anxiety, it's inconvenient, and it can be a cost to women to have to come back and have extra imaging. 3D mammography also has better cancer detection. Its radiation dose is a little bit higher, but with the synthesized views, that total radiation dose is actually reduced and very similar to 2D mammography. Maybe go to the next slide, please. Okay, so on the right-hand side, you can see it says just right MLO and left MLO views, and that's basically a 2D mammogram. And on the other side, where it says C views, you can actually see this is our synthesized view. So what we were just talking about decreasing the radiation dose from 3D mammography, we can obtain these synthesized views where we don't actually take a 2D mammogram, we just take multiple images and slices and we make a 2D mammogram from those images. You can go to the next slide, please. And I'm not sure, but if you want to hit the play button on these, I'm not sure if the videos will work. Yeah, so this is basically a tomosynthesis view. You can see how we get to scroll through the breast tissue on either side, and it actually lets us figure out what's overlapping tissue and what's actually real. And so, you know, when you look at a 2D, when you take a 3D object and you turn it into a 2D image, right? You basically have a whole bunch of overlap, right? Everything that's in that 3D object from, you know, the right to the left is going to show up on that same screen. But in tomosynthesis, we get to slice through it in these little tiny slices, 1 millimeter slices. And so then you can kind of see like, oh, that's just tissue. Like that's not something that's real. It's not a real mass. We can go to the next slide, please. Okay, so this is a 2D mammogram again, and you can see it's, without being able to point it out, in the upper outer part of the right breast, there's actually an area of architectural distortion, but it's very hard to see. And if we go to the next slide, on the tomosynthesis views, it actually stands out a little bit more. So if we hit play, and then stop, Okay, that's okay. You can actually see, yeah, yep, keep going. Okay. And then stop there, yeah, on either side. It doesn't, well, anyway, you can see that there are areas of distortion in there that are better seen on the tomosynthesis 3D mammograms. You can go to the next slide, please. So this is just the ultrasound showing the mass that we could see on the 3D mammograms better. You can go to the next slide, please. And then if you hit play again, this is just the MRI looking for other areas of cancer after we've already found that one cancer. And you can look in the lower right-hand breast, you'll see that area that pops up brighter, and that's the mass. Okay, we can go to the next slide. So I just sort of wanted to give you all an example of what tomosynthesis does and what it looks like to us when we're reading, and how it's helpful in the sense that we basically get these little tiny slices through the breast that all help us sort of see into the breast better. So the next question that we asked is, why is screening mammography important? As we talked about, breast cancer is the most common cancer diagnosed in women. 1 in 8 women will be diagnosed in her lifetime. It's the second leading cause of cancer deaths among women. About 43,000 women are expected to die from breast cancer in 2021. And breast cancer accounts for about 30% of all new cancer cases in women. We can go to the next slide, please. Question is, has mammography reduced breast cancer deaths? And the answer is absolutely yes. So if you look at this graph, basically it's a straight line up until about 1989, when mammograms became more widespread. And so in 1989, we had a dramatic decrease in breast cancer mortality, about 42% decrease in breast cancer mortality. Can you go to the next slide, please? So the benefits of screening, like we said, about 40% drop in breast cancer deaths. They're, usually for the women who get screening mammograms, they get less extensive surgeries. They also usually get less chemotherapy, and chemotherapy is more effective for screened women. This is also very important in terms of detecting a breast cancer early means that it's easier to treat. Next slide, please. So who should get their mammograms and when? Women at average risk for breast cancer should start their annual mammograms at age 40. Women with higher than average risk of breast cancer should start annual mammograms at an earlier age with possible supplemental screening. And I think that Mrs. Taylor also talked about that. In terms of asymptomatic, meaning no breast problems, this is actually really important. So if you have a lump, if you have nipple discharge or something like that, you shouldn't get a screening mammogram. You should actually let the scheduler know that you have a breast problem and be scheduled for a diagnostic evaluation or diagnostic mammogram instead of a screening mammogram. Because these screening mammograms, they're not read while women wait, they're actually read the next day typically. And so, we want to know if you have a breast problem, and then we want to see you in person so that we can basically do all of the different imaging exams needed at one time. And then in terms of frequency or when to get it, annually, meaning every year, we recommend. You can go to the next slide, please. Okay, so why start screening at age 40? I think everyone has talked about this, but breast cancer is a really important issue for women in their 40s. 1 in 6 breast cancers are found in women ages 40 to 49. Women in their 40s develop more aggressive cancers, so younger women get more aggressive cancers. And then half of all fatal breast cancers are diagnosed before age 50. So these are big numbers, and this is why it's important to start at age 40. Next slide, please. Again, just to reiterate, 40% of all the years of life saved by mammography are among women in their 40s. Starting screening at age 40 will save 100,000 more lives every decade than starting at age 50. And, American College of Radiology, Society of Breast Imaging, American Society of Breast Surgeons, the National Comprehensive Cancer Network, all of basically the specialists in breast cancer care all recommend starting at age 40. And the next slide, please. Okay, so if you have a normal screening mammogram, they're interpreted by a breast radiologist, typically read without you waiting there for the immediate results. And then those results will come to you in a letter, and they will also go to your provider. And usually the recommendation will be screening in 1 year. Can you go to the next slide? If it's abnormal, meaning that there's something that is not normal on the mammogram, it might be for a variety of reasons. One, something looks a little bit funny on the mammogram and we want to do extra views just to look it up. And that doesn't mean that it's cancer, but it just means that we need you to come back in to look at it a little bit more closely. It might be that it's an incomplete study. Maybe there's motion on the mammogram, and so that's called a technical repeat. Or it may be that we just need to find your prior mammograms, and our center actually will work to obtain your prior mammograms from other sites and other facilities, and then we'll compare those and decide whether or not, something has been unchanged and is the same for many years, or if it's something that's new. And then these results also go to you and also to your provider. Next slide. Okay, so diagnostic evaluations. Kind of briefly talked about it when I was talking about screening. So diagnostic evaluations, what are they and who should get it and when? So we can go to the next slide. Okay, so diagnostic evaluations, they may start with the same views as a screening mammogram. So even though it's called a diagnostic mammogram, we may start with the same compressed views as the screening mammogram, but we also may get extra views and other views. We also have breast ultrasounds that get performed at the same time. Images are interpreted and reported while patients wait. So you will receive your results immediately after finishing all of the exams. The next slide, please. It's just an example of what a breast ultrasound looks like. We can go next. Okay, so who gets the diagnostic mammograms and when do they get them? So if you had a finding that looked funny on your screening mammogram and your screening mammogram was not called normal, you would potentially be called back for a diagnostic evaluation. If you have a breast issue or a concern, so lumps, focal pain, nipple discharge, these are things that we want to know and we want to help address. So we want to know about these, and then we have a lot of different ways that we can look at them through mammogram and ultrasound and other ways. And so a history of breast cancer, findings that require follow-up, all of these things may mean that you end up getting a diagnostic evaluation instead of a screening mammogram. Okay, next slide, please. And this is just an example. You can see in the left breast on the right hand side of the screen, I guess, is an area where the nipple looks like it's pulled in and it's just more dense and there's a mass. If you want to go to the next slide. So when you compare, you can see that the nipple looks like it's pulled in on the mammogram and there's a mass on the mammogram in the left breast. And then you can go to the next slide. And this is the ultrasound. So these are, what we basically would be doing in a diagnostic workup. So we would do the mammogram and, we got a few extra views as well, but then we also do an ultrasound and we can see that there's an irregular mass in the breast. And then you can go to the next slide, please. And then we also sometimes will look at the lymph nodes or in the armpit, in the axilla, and these lymph nodes also look abnormal. Go to the next slide. Okay, so diagnostic evaluations, we don't have to go through all of these. Basically, they're categorized from being negative or benign and not cancer to being cancer, or if somebody's undergoing chemotherapy, then we know that it's a cancer already and they're getting treatment. We can go to the next slide. So for next steps, if it's abnormal, then oftentimes you'll need a biopsy for diagnosis, and the breast radiologists perform the image-guided biopsies. We do ultrasound-guided biopsies, stereotactic guided biopsies, MRI-guided biopsies. These are all same-day procedures. There's local anesthesia, no sedation required. And patients can drive themselves home, although it's nice if people bring someone with them and they can drive themselves, they can help drive home and things like that, but you won't have any sedation for those procedures. Yeah, the next slide, please. So this is just pictures of our stereotactic guided biopsy unit. Yeah, the next slide. After a biopsy, we call our patients with their results. We talk to them about what those results mean and what the next steps are. So, maybe the biopsy is benign, meaning it's not cancer, and we can return that person to the screening mammogram. They may need to be seen by a breast surgeon or a medical oncologist if it is cancer, and so we would refer those patients to breast surgery or to other specialists. Next slide, please. Okay, and so the last question is, where can I go to be seen? And we have multiple different sites that are ready for anyone who wants to come in. We have the Moody Center for Breast Health. You saw the video. It's beautiful. It's amazing. We have brand new equipment. We have cutting edge equipment in terms of it's all tomosynthesis, all 3D mammography capable. We have Southeast Dallas Health Center, and that's also 3D mammography capable. We also have a brand new mobile van, and you can see that purple van in the picture. It is also 3D mammography capable. And so it's really exciting that we now have 3D mammograms for everything. And then coming to Redbird soon, when we open in February 2022, will also be another 3D mammography capable unit. You have the next slide. Thank you.
Okay, I'd like to say thank you to our panelists and to let you guys know that we do have questions. Before we get into the questions, each segment I've really learned something that stuck with me today. Aisha, I love the visual with the lemons. That just worked for me. Dr. Hayes, thank you for continuing to address and answer questions, to address the myths that are out there today. And this last session, the benefits of the screening, that's the thing that stuck with me this time, just seeing how when things are detected earlier, the treatment seems to be less aggressive. So thank you, ladies, for all of that. This has been a lot to learn and to try to remember. But what I would like for you guys to know that when individuals come for their screenings at Parkland, we do provide the education again. We're not expecting you guys to remember this all the time. And of course, the professionals are here to address your questions. So let's get into some of those questions now. The first question I have is, does menopause decrease your risk of breast cancer?
I wouldn't say it decreases your risk, because one thing to keep in mind is your risk of breast cancer continues to go up every year that you're here on Earth, basically. So the older we get, the higher our risk of breast cancer goes. And so when women are going through menopause, they're already over that 55-year-old age, or around that 55-year-old age, which is where we are diagnosing more of the cancers. The one thing, so when you go through menopause, that decreases the estrogens, so it takes away that estrogen, but women a lot of times will go, or sometimes will do hormone replacement, which hormone replacement therapy has been documented to significantly increase your risk of breast cancer. So that's something to be very aware of. The hormone replacement for menopause symptoms is definitely a concern.
Okay, thank you. And we have time for maybe 2 more questions. The second question I have is, can you get breast cancer if you've never had children?
Yes. So the answer is you can get breast cancer if you've never had children. You can get breast cancer if you've had children. And that's kind of what I think Dr. Hayes was showing. About 70% of women in history don't have necessarily risk factors for breast cancer, but it's sort of spontaneous. It kind of happens.
Okay. Another question says, if breast cancer is detected on one breast, can a double mastectomy be performed?
Yeah, so again, yes, it's a conversation to have with your physician and your breast surgeon on what treatments are offered and being are the best in terms of how to treat it. But yes, if people do undergo a mastectomy to treat one side for the breast cancer, and they undergo a mastectomy on the other side to prevent breast cancers in the future, or to help with symmetry in the sense that sometimes it's easier if both of them get reconstructed at the same time to have similar looking and similar sized breasts.
Okay. Thank you, guys.
One thing I would like to add is, just so everyone is aware, taking a breast off, doing a mastectomy, definitely decreases your risk of breast cancer, but it does not make it 0. So it decreases the risk 90%. There's still a 10% risk of breast cancer after you've had a mastectomy. So it is extremely important that you keep up your breast exams even after you've had a breast removed.
Okay, thank you. I have time for no more questions, but please keep in mind that we are here all week. We are Saturday, once again, at Salem Institutional Baptist Church. So if you have questions, please continue to bring those questions. Please continue to show up for your mammograms. And today at 1 o'clock, we have the Spanish version of the session that you just saw. So thank you guys so much for your time and continuing to provide education to the community that we serve. Goodbye.
Thank you. Bye.
Thank you.
Thank you.